Good evening, one and all. A warm welcome to everybody to the academic session hosted by Yashoda Hospitals group of hospitals. Okay, so I'm Dr. Vinilh. I'm working as head of the department Yashoda Hospitals Secunderabad branch. Today we are here to talk about status epilepticus. So now we have Dr. Surendra sir on board as a speaker for this talk. He is having almost 20 years of experience in emergency department. So now I invite Dr. Surendra sir to take over the lead. So you can go ahead.
Yeah. Thank you, Vinith, for your introduction.
Yeah.
Right. Again, good evening, everyone, all the participants. And I thank the organizing persons for giving me this opportunity, and especially so to my friend, Dr. Srinath, who is my classmate. So, let us go to the topic proper. So, status epilepticus. So, the name itself is very disturbing, both for the patient as well for the treating doctors and the nursing staff, because the things are so ugly looking, and also even the attenders also are very concerned about the problem. Hence, it is our motive to bring down or even totally stop the episodes. So in such a way that the further damage on the mortality, morbidity, as far as possible, should be curtailed. So what is status epilepticus? It's a seizure episode which is lasting for or equal to 5 minutes continuously, or there are discrete seizures in between coming, but during those periods of post-ictal phase, patient will not regain consciousness during those interictal period. So if any of these two are met, then the person is are diagnosed to be having status epilepticus. So next slide, please. So status epilepticus, grossly, they are being classified into two varieties. One is generalized convulsive status epilepticus, and another one is non-convulsive status epilepticus. To recognize a generalized convulsive status epilepticus, it may look very simple and also, but it looks very odd or very disturbing. But it is very easy to witness or observe those things. So there will be a persistent generalized electrocardiac activities associated with coma. So they will have some tonic-clonic movements. So it is very easy to recognize. Whereas the non-convulsive status epilepticus, usually they may present with persistent absent seizures or sometimes focal seizures. So with some confusion, partially impaired consciousness, or some minimal motor abnormality. So this is requires little more focus and also understanding, especially so in non-convulsive epilepticus. Next slide. So what are the common causes for this status epilepticus? So among most of the status epilepticus, commonly we come across one is cerebrovascular diseases, that is cerebrovascular accident. That is commonly we come across most often intracerebral hemorrhage. That is the most common cause for one of the presentation in our setup. And the second most common is metabolic derangements like hyponatremia. So, and very rarely we see hyperglycemic induced seizures, which are status epilepticus. Next slide. So among other conditions where we can get status epilepticus are tumors, especially the malignant tumors, and even infectious diseases like abscess also present with status epilepticus. And some of the toxins, especially alcohol intoxication or withdrawal, or some of the drugs like which have been withdrawn suddenly, like barbiturates withdrawal, can also present with status epilepticus. Whereas other drugs like penicillin, cephalosporins, though it is mentioned, so we have not seen so far such people coming with status epilepticus at least. Next slide. And following trauma, either epidural or subdural hematomas or subarachnoid hemorrhage or another etiology where we can get status epilepticus. And in some of the diseases like chronic renal failure or cirrhosis of liver and even some dementias also in elderly people, there are chances that patient may present with status epilepticus. Next slide. So what is the pathophysiology? Why they will have seizures even for more than 5 minutes? So that we need to understand. As the seizure surpasses 5 minutes, the threshold for seizures is greatly diminished. So this can happen because of decreased expression of internalization of GABA receptors and also increased expression of glutamine and N-methyl D aspartate receptors. That's one of the reasons. Then because of the epilepsy, so patient may have a compromised blood-brain barrier, which leads to the penetration of hyperexcitatory CNS chemicals. So like potassium and albumin, which can seep into the or cross the blood-brain barrier and which can cause hyperexcitability of the neurons. So that is another. Next slide. So this can lead to transformation of a normal neuronal network to a chronically hyperexcitable state. Normally, they may not be having that excitability, but because of these reasons, so those neurons can become hyperexcitable. So as we already discussed, there is a reduction in seizure threshold. So sometimes there is often a delay of months to years between CNS injury like following trauma or infections or stroke and the first clinical evident seizures. So it can go on for many months or even up to a year. So later on, they may present with seizures episodes. Next slide. So if we know the complications, it is not like a single or 2, 3 episodes of seizures, which may not have much morbidity and mortality. But whereas in status epilepticus, we need to know the complications, because unless we address them or treat them as early as possible and try to arrest the convulsive episodes as well as non-convulsive episodes, so some of the complications may be life-endangering. So hence, it is always better to know complications which may arise if the seizure episodes are not curtailed as early as possible. So some of the complications are common complications are, so they may develop cardiac arrest or arrhythmias. So they may develop apnea or sometimes severe hypoxia and hypoxic-induced brain damage. And then hyperthermia because of convulsive episodes, metabolic acidosis as there are more cellular activity. Then because of the, again, convulsive episodes, they may develop rhabdomyolysis, acute kidney injuries, and of course, some of the other things like fractures. So also can because of the repeated convulsive episodes. So, and also sometimes patients may present with irreversible neuronal injury following the recovery. So that is another one which we should be very careful, even though we may succeed in aborting the status epilepticus, but the time period which we take may not is not enough to prevent this irreversible neuronal injury. So so in that way, we should act very fast and we should know the proper management skills in the status epilepticus cases. Next slide. So some of the investigations which we can do, of course, blood sugars, even hypoglycemia or hyperglycemic states also can present. So hence, and of course, CBC, LFT, RFT. The most important is serum electrolytes and some of the magnesium levels or calcium levels. And of course, lumbar puncture, all those things can be done later. We cannot do when there is such a episodes. So then other like toxicology screening and patients who are on anticonvulsant drugs. So we need to get drug levels so that we can know is there any withdrawal or the blood levels are reduced so that may be there is withdrawal of the, suppose patient has missed the doses. So we know that is the one of the reason for status epilepticus. Later on, once he is stabilized, you can get a MRI, or if there is a uh, if necessary, even we can get a non-contrast CT brain if, immediately if it is required. Then coming to EEG, it is definitely a very helpful tool, which we are going to discuss how it's going to help in our diagnosis as well as in the management. Next slide. So any seizure which has got activity of up to 5 minutes, as been discussed in the introductory slide. So any seizure which is lasting for 5 minutes, or the patient is having intermittent seizures, but interictal phase, if he is not regained conscious, it is going to be labeled as status epilepticus. So what is the first thing as emergency physician? You all know that it is the most important thing is airway, then breathing has to be, ABC has to be taken care, airway breathing, then followed by if the patient having any oxygen hypoxia or saturation is low, you can get it. And immediately we can get a GRBS, so that it can be treated very easily. So which is a very simple thing. And the next most important is patient protection from any injuries, because you will be having continuous convulsions. So we need to take care of that part. So once the established status epilepticus, so we are going to give the injection lorazepam, and sometimes people also use diazepam, but most commonly in our center and even in most of the centers, I believe they give lorazepam in the dose of about 0.1 milligram per kg IV. And then along with that, one of the following, either IV phosphenetine, so or even regular phenytoin. So only advantage is by giving we can give very quickly, whereas phenytoin has to be given over a period of 20 minutes like that. So hence there is a delay. So hence if it is not phosphenetine is not available, then only phenytoin should be considered. Otherwise, the best drug would be phosphenetine. So it is given at a rate of around dose of around 20 milligram per kg at around 150 milligram per minute. So whereas phenytoin has to be given at around 50 milligrams per minute. So it requires it is a time consuming, hence phosphenetine is preferred. Next slide. So once we give that, so and so anyway, this will take about 5 to 10 minutes or like that, and we'll have to watch. And if the persistent seizure activity, despite the IV administration of these anti-epileptic agents, and if it is exceeding even after 30 minutes also, if the seizure activity is still happening, then we will have to consider it as refractory status epilepticus. So once we give lorazepam plus phosphenetine, and if it aborts, it's well and good. Suppose if the seizure persists even after giving this and exceeds 30 minutes, then we'll have to consider it as refractory status epilepticus. Next slide. So in the next 30 minutes, what we are going to do? So the first thing is we'll have to go for IV midazolam or propofol, and sometimes ketamine also can be given because some only disadvantage is we cannot give ketamine. There is a risk of, if it is a raised intracranial tension, and because it causes hypertension, so it may increase the intracranial tension. So may be avoided in those cases where you suspect ICSOA. Whereas the best drug would be midazolam or propofol, or the recent one also suggests even IV levetiracetam. So they are all given in the dose what has been mentioned in the slide. So midazolam infusion at a rate of around 0.2, whereas propofol 1 milligram per kg, and levetiracetam 20 milligram per kg. So earlier we used to use even phenobarbital also, but somehow the success rate is not so good with phenobarbital. So hence we have not using in the last few years. So we try to give any of these three drugs. So these are the drugs which we need to give. And once these drugs are given, because we have already considered it as status epilepticus, so we need to intubate the patient, and if necessary, if it is convulsive, we need to paralyze the patient by giving either succinylcholine or rocuronium and put him on a ventilator in a neuro ICU. And we should not forget that we should continuously monitor EEG, because a non-convulsive status epilepticus can go on one, or when we use paralytic agents, so we may not see any convulsive movements, but the brain activity which is ongoing may be missed if we do not connect it to EEG in the ICU setup. So in conclusion, non-convulsive seizure requires clinical suspicion and EEG, unlike convulsive seizures. Prompt recognition of precipitating factors, because many times we do give all the anticonvulsant drugs, but still we will be struggling to abort the episodes, because there will be some precipitating factors or causative factors like electrolyte disturbances or hypoglycemia or hyperglycemia. So those things need to be addressed because which can be done very early, so that the chances of aborting the status epilepticus will be high. So hence we need to recognize the precipitating factors or causative factors, and treating them appropriately will help in management of the status epilepticus. And then, of course, once it is established, judicious use of anticonvulsants, paralytic agents, assisted ventilation, all these things as early as possible should be aborted, so that the morbidity and mortality can be definitely brought down, and we may have a good outcome. So next slide. So with that, I end my talk today. And if there are any questions, if possible, I will be able to answer that, and also open to the forum.
You can use chat box or QA section to post your questions.
If you have any questions, you can ask viewers. Please post there.
Regarding diazepam, sir, I think if IV access is not yet established, the suppositories will make a good choice, I guess.
Yes, definitely. Yeah, there's a good choice for because we do have, as you said, the non-IV route are very easily available. Diazepam, unlike lorazepam. Yes, you are right. You are right.
Is there any? There's a question,
Yeah.
sir.
Yeah. I'll go through that.
Yeah, you can have a look.
No, not only host and parents. Yeah, one question is there. I'll just go take the first one. Any specific or ideal drug for sedation or paralysis?
Paralysis in patients.
Yeah. Sedation, yes, because again, midazolam is a very good drug for persons, but in some patients where there are chances of respiratory, if we are dealing with this one, then we can even go for ketamine. Otherwise, best drug would be midas. Then
there's one more question.
Any other opinion from your side? You can always
yeah,
intervene.
You can.
If some patients, if some referring
hospital has referred to our hospital, and in our ED, if patient gets seizure episodes, what drug should we use?
Yeah, the next best drug would be levetiracetam. We do use levetiracetam a lot. That is the best drug. Earlier we used to use phenobarbital. Somehow the results are not so promising in our setup. I don't know. But we are using levetiracetam. We have got very good results.
Yeah. Okay.
Otherwise, even phenobarbital can also can be used.
Yeah. What's the maximum dose of lorazepam we can give, sir? Another question.
Maximum dose. Okay, I forgot about the dosage. I'm sorry if anybody can answer. I think it is around 4 or 5 mg. I think
Generally,
I'm not
we
sure.
go
I'm
with
not sure.
0.1 mg per kg like that.
Kg per
So
kg.
generally, we
Yeah.
go with 4 mg.
4 mg.
Yeah. Yeah.
And whatever kind of benzodiazepine you are choosing, you are supposed to use it for 3 times. Say your
Yeah.
ambulance is bringing a case and the EMT has already used 1 dose. You can use 2 more doses here. So whether it's midazolam, diazepam, or lorazepam. So you can try up to 3 times only. Then you have to move to other kind of drugs. This is as per UK guidelines.
Yeah. Yeah. Okay.
There's one more question, sir. Can we use midazolam nasal spray?
We have not. We don't have any experience about that. So we have not used so far. I don't know if you have anybody is using it or if anybody has got a experience of that, they can answer. Frankly speaking, we don't have nasal route. Anybody has used?
Nasal, we will have to see the dosing and all, how much each spray is going to deliver. So that way we can use. And if unable to get IV access, can we go with our nasal rectal? That's one more question. Yes, rectal we have discussed already. So yeah, when you don't have an IV access, buccal, rectal, nasal, all routes are acceptable. Yes, same dose.
So only thing is there's a concern regarding the absorption, especially with the nasal, because there are maybe there are very less number of studies so far. So whereas rectal, I feel there is a good number of people are using it, but nasal, I'm not sure.
I think the questions are done, sir.
Okay.
Is there anything else, guys? There's one more question, sir. Nasal spray in pediatric is good. Febrile seizures, it's good and it's also easy for parents to use at home. Yeah.
Yes. For pediatric, yes, we can.
Yeah, that's from
Here
Dr.
in
Mohammed Mustafa. Thank you.
Status epilepticus, sometimes it may be difficult because the absorption at the nasal level is not, I don't know, but if they are using.
If it is at home, we can use it, sir.
Yes.
Yeah. So there's one more question, sir. Can we go with IM or IV or rectal? Is not approachable.
IV or rectal is unapproachable. The thing is, the absorption delay may take place. So when it is nothing is available, yes, you can go ahead, but do not try to give IM when even with 1 or 2 attempt of not available IV, because again absorption delay and so in status epilepticus, yes, it is not. Earlier we used to give phenobarbital as an IM, which has got a bit good results, but phenytoin we have not used IM, but phenobarbital, yes, we can use IM.
There's one more question, sir. If we give rectal, Midas is better or Loraz is better?
See,
I don't think Loraz is available in rectal suppository
rectal
form.
forms. I don't know. Yeah, availability is the problem. Again, we'll have to go for diazepam. So we cannot compare with the Loraz and Midas.
Yeah. I think we can end it here, sir. There are no more questions.
Yeah. Okay.
Thank you, sir. Thanks a lot for your wonderful session.
Thank you, one and all, and thank you for giving me this opportunity. Thanks once again.
Thank you, sir.
Okay, we'll close it now.
Yeah.
Shall I exit?
Yeah.
Okay, fine.
So thanks a lot, everyone, for being in this session. We'll catch up next week with another topic, another interesting topic. And thanks a lot, Yashoda Hospitals, for giving this forum for an educative thing. Thank you, Dr. Srinath, sir, for organizing this session. Thank you, Naveen.